Hey everybody, you know what this is? High yield step 1 questions. Let's get right into it. A 27-year-old woman presents to the emergency department with complaints of increasing shortness of breath, fatigue, and swelling in her legs the past week. She mentions that she feels more shortness of breath when lying flat and often wakes up at night feeling breathless. Her medical history is significant for the delivery of a healthy baby girl 6 weeks ago. Prior to her pregnancy, she had no significant medical issues. Her recurrent medications include only prenatal vitamins. On physical examination, her temperature is 98.2, heart rate is 112 per minute, blood pressure is 110/70, respirations are 22 per minute. Jugular venous detention is noted, and auscultation of the chest reveals bilateral crackles. There is a +2 pitting edema in both lower extremities. Her chest x-ray shows cardiomegaly and pulmonary vascular congestion. Which of the following conditions is the most likely diagnosis? All right, to crack this question, you have to think like a cardiologist would. We have a young postpartum woman who is now showing signs of congestive heart failure. Some important signs in the question are orthopnea, that's the shortness of breath when she's lying flat, the paroxysmal nocturnal dyspnea, or PND, that's the waking at night and she's gasping for air, and also the leg swelling, and the JVD, and the pulmonary crackles. That means there's volume overload. So those are classic signs of systolic dysfunction, and given her postpartum status, the condition points to peripartum cardiomyopathy. And peripartum just means done or occurring shortly before or after labor and delivery. So this is like 6 weeks postpartum. So perfect timeline for peripartum, right? Orthopnea, PND. And that tells us that there is probably left-sided heart failure. There's a crackling, the JVDs, the pedal edema. That's pulmonary and systemic congestion. And so you have cardiomegaly on the chest x-ray. That means there's a dilated heart chambers. So she probably has the dilated, weakened left ventricle that can't pump the blood forward. And so instead it causes a backflow up to the lungs and the venous systems. Now, there are a couple of associations that are sometimes relevant for STEP. This is more common in African ancestry, so higher incidence in Black women. And also each pregnancy increases the risk. Also tocolytic use like beta agonists can contribute to cardiac stress. And for the diagnostic criteria, you look at the ejection fraction, and if it's less than 45%, that would be very important for the diagnosis. And that can actually progress to a fulminant heart failure or even require a transplant. And so the pathophysiology here is you have a pregnancy-induced hemodynamic stress. So you increase the blood volume and the cardiac output, and then you get myocardial remodeling. And that leads to the left ventricle dilation and the systolic dysfunction. And so you get dilated chambers. You decrease the ejection fraction, the fluid backs up into the lungs and the systemic circulation. And if it's untreated, then it can lead to a thromboembolism or arrhythmias or a cardiogenic shock. And there are some key features here like the S3 sound. That's whenever you have volume overload, so it makes sense that you'd see that S3 gallop, and the displaced apex beat, which means that you have left ventricle dilation. So you have cardiomegaly, pulmonary vascular congestion, and of course that ejection fraction is less than 45% in echocardiogram. That's the super important diagnostic test. Now, why is it not, let's say, acute viral myocarditis would be a recent viral illness, and that's not mentioned. And that's usually in like younger males and kind of just different presentation. Deep vein thrombosis, that'd be a unilateral leg swelling and no JVD or crackles would be seen. So that's not the right answer. Mitral stenosis would be a diastolic murmur. So you have rheumatic fever, and anxiety disorder would be like hyperventilation. You'd also see normal vitals on an anxiety disorder. And this patient has some very clear objective findings. They got JVD, they got edema, they have that kind of stuff. And so basically this is heart failure in a young, healthy mom weeks after delivery. So it's peripartum cardiomyopathy. And usually this is going to be in the last month of pregnancy or within 5 months postpartum. And they have orthopnea, paroxysmal nocturnal dyspnea, JVD, crackles, and leg swelling. And all that is going to be the left-sided heart failure. So the bottom line is peripartum cardiomyopathy should be suspected in a postpartum woman with heart failure symptoms and no prior medical history. All right, for this next question, I'm going to need you guys to memorize this photo right here, this diagram, great saphenous, anterior branch, posterior branch, and the greater saphenous right here. There's our popliteal vein and the lesser saphenous as well. So just make sure you're looking at these diagrams, try to memorize them as best as you possibly can. The veins of the leg, you have the external iliac, the femoral, the perforating veins right here, and the great saphenous is on this medial portion. There's the small saphenous vein and the dorsal venous arch. One more photo, here's the great saphenous vein, and then there's the small saphenous right there. You can see we're looking at the back of their leg right here. By the way, legs are super heavy. They're always heavier than you think. I remember in an anatomy lab lifting up a leg for the first time, and I was like, man, like just a leg. And I was like, wow, that is heavy. Saphenous vein, tributaries of the saphenous vein, great saphenous vein. Cool, let's do a practice question. So here we have a 45-year-old woman undergoing surgical preparation for vein harvesting to treat chronic venous insufficiency. The surgeon plans to use the great saphenous vein for venous bypass. Where should they make the incision? All right, if you remember those diagrams, then it's going to be just anterior to the medial malleolus. So the great saphenous vein runs just anterior to the medial malleolus, and it's the most accessible site would be right there, D, for vein harvesting. And it's going to be superficial and it's like super consistent. It's really easy to identify. And it's going to ascend from the foot medially up to the femoral triangle. But the ankle region is going to provide the easiest entry point. All right, it's not the lateral malleolus. There you'd think the small saphenous vein, not the great saphenous vein. So it's the wrong like anatomical side there. Posterior calf, the Achilles, that would also be the small saphenous vein. That's the wrong vein, wrong purpose. The femoral triangle, that drainage, that's the drainage point of the great saphenous vein, but it's not going to be optimal for the initial access. So not quite it, Chief. And E, behind the knee joint, is going to be the popliteal region. So that's deeper and it's not used for superficial harvesting. So the key takeaway here is that the initial incision for great saphenous vein should be just anterior to the medial malleolus. All right, this question is truly fascinating. There's a 54-year-old woman, and you can see here, I actually love this picture. I think it's a really good illustration of what's going on here. She arrives at the urgent care clinic with sudden left arm pain, pallor, and coldness that began approximately 3 hours ago. Her medical history includes a recent diagnosis of AFib. She's on warfarin for anticoagulation, and her latest INR is 1.5. On physical examination, her left upper limb is cold and pale, with the absent pulses distal to the brachial artery. Capillary refill is delayed and sensory loss is present in the fingers. Which of the following is the most likely diagnosis? Now, you might have been tempted to choose Raynaud's phenomenon, a phenomenon, or whatever that song is. But that actually has a triphasic color change, and that's with cold and stress. So Raynaud's is going to be episodic, and also it's symmetric. It's not going to be pulseless either. So it's not that, even though everybody likes to choose that whenever there's anything weird going on with the fingers or hands or what have you. But for this one, I think we'll just talk about the relevant facts for this case. And that is that we have the sudden cold and painful pulseless limb. And the very important part here is that it's pulseless. What does that mean? That means you have some sort of arterial occlusion probably. So you have an arterial blockage. And AFib mixed with that subtherapeutic INR means it's the prime setup for some sort of an embolism. And so the lay of the land for this question, to interpret this case correctly, you have to combine the cardiology and the vascular emergency knowledge together. And so if a patient has atrial fibrillation, that's a rhythmic disorder where the atria is going to quiver instead of contracting. And that causes stagnant blood flow, and that can promote the formation of clots, especially in the left atrial appendage. And so when anticoagulation is subtherapeutic, that's the INR of less than 2, then the thrombi can actually dislodge and it'll travel through the atrial system. And that is just a classic embolism. And this patient is presenting with the 5 Ps of acute arterial occlusion. All right, so let's write those out because they are important to know. Pain, pallor, pulselessness, paresthesia. And this last one is interesting. It's poikilothermia. That's coldness that fluctuates with your environmental temperature. And so that means we have a vascular emergency and you need rapid correction, right? So this is atrial fibrillation. That's the embolic source. You have inadequate anticoagulation because we have 1.5 on warfarin. And there's that sudden limb coldness, the pallor, the sensory loss, absent distal pulses. That's going to be an embolic arterial occlusion. And there's a capillary refill that's delayed, and that means there's some sort of an impaired arterial inflow. And so this is all just telling us it's going to be some sort of an atrial embolism. So it's a left-sided emboli because if it's left-sided, then it can go straight to the brain like in a stroke, or it can go to the peripheral arteries, and that causes limb ischemia. And this is very time sensitive, right? Greater than 6 hours means that there's a big risk of irreversible limb ischemia. So let's look at these answer choices here. Raynaud's, we already kind of covered that one. Acute hemorrhaging, that would be with like hypotension, tachycardia, pallor. And that would definitely not be causing unilateral limb symptoms with pulselessness. So C is going to be our answer, embolic arterial occlusion. Brachial plexus injury is totally not going to be our right answer because that's going to be weakness and sensory loss. They're not cause coldness or pallor or absent pulses. That's a nerve issue, not a vascular issue. Thoracic outlet syndrome, that's going to be like a chronic positional symptoms that's going to present more gradually and not with like a sudden vascular compromise. And so every 5 minutes, somebody with an AFib is going to throw a clot. Happens pretty frequently. In fact, you should think of AFib clot, when you're taking this exam. And sometimes this doesn't go to the brain, instead it goes to the limb. And so here we got this 54-year-old woman. She's got AFib. She's got a subtherapeutic INR. And that basically means that she is not being properly anticoagulated. And so this is going to show up with a cold, pale, painful arm, and there's no pulses, and there's delayed capillary refill. And so there's a cardiac embolus that's lodged into the brachial artery, and it's cutting off the blood supply to her forearm and her hand. And that is called an acute arterial occlusion. And that is one of the few limb-threatening emergencies that you actually will see on the Step 1 exam. Okay, so the bottom line is embolic arterial occlusion is likely due to atrial fibrillation and presents with sudden limb ischemia. In this question, we have a 29-year-old woman who presents to the clinic with postcoital bleeding and persistent pelvic pain. She reports that her last pap smear performed 3 years ago was normal, and physical examination reveals a friable lesion on the anterior vaginal wall. A biopsy is performed and reveals invasive squamous cell carcinoma. In this patient, cancerous cells are most likely to metastasize first to which of the following nodes? Okay, so we got to talk about the lymph. And the lower 1/3 of the vagina drains to the superior inguinal lymph nodes. And squamous cell carcinoma is the most common vaginal cancer. And this usually arises from the posterior or the anterior vaginal wall. And so to solve this question, we have to know a little bit about the pelvic lymphatic drainage, especially in the vagina and the vulvar regions. And so the vagina has a dual lymphatic drainage pattern. The upper 2/3 drains to the internal and the external iliac nodes, and then the lower 1/3 drains to the superficial inguinal nodes. And so she has a lesion on the anterior vaginal wall, and then also the postcoital bleeding with the biopsy proven squamous cell carcinoma is going to be a common presentation for some sort of like a vaginal cancer. And so the location of the lesion is very important, and it's lying on the lower third. And so that makes it the superficial inguinal node is going to be the very first sign of metastasis, the site of metastasis. And that is why our answer is C. So the postcoital bleeding is a common red flag for cervical or vaginal squamous cell carcinoma. And the anterior vaginal wall lesion suggests that it's the lower vaginal involvement. And the friable description is going to be the ulcerated or malignancy. And the invasive squamous cell carcinoma is the most common histological type of vaginal cancer. And this has several associations that are important to know, like HPV, especially 16 and 18. And that's associated with squamous cell carcinoma of the cervix and the vagina. Squamous cell carcinoma is the most common type of vaginal, vulvar, and cervical cancer. And the lymphatic spread is going to follow the embryologic origin and the anatomical locations of the lesions. So the superficial inguinal is going to cover the lower 1/3 of the vagina, the vulva, and the anal canal below the pectinate line. And that can be kind of weird because it's below and then you think superficial, but it's one of those things you just kind of have to memorize. And the pathophysiology kind of goes with, at least with HPV, is that you have some sort of an HPV infection or like a chronic irritation, and that triggers some sort of like a squamous dysplasia. And then the dysplasia evolves into invasive squamous cell carcinoma. And if the lesion is on the lower third, then it metastasizes first to the superficial inguinal. And if it's untreated, then the cancer will spread upward and it'll go deeper and interact with the external and the internal iliac and the periaortic. So the postcoital bleeding really tells you that it's the vaginal or cervical cancer. The friable anterior vaginal wall means that it's in the lower third, superficial inguinal. And the squamous cell tells you that it's HPV associated because that's the most common, especially in the lower GU tract. And then you have to know the lymphatic spread is in the lower 1/3 is superficial, and then the upper 2/3 of the vagina and the cervix are going to be the iliac. If it's in the ovaries or the testes, then that's always para-aortic. All right, and so that covers most of these questions. The bottom line is invasive squamous cell carcinoma of the vagina typically metastasizes first to the external iliac lymph nodes. Now, please note that this would be the lymph from the lower rectum to the anal canal above the pectinate line. So this bottom line right here is referring to the cervix, the upper vagina, and the uterus, but not the lower 1/3 of the vagina. This question is asking about the lower 1/3, but the bottom line here is about the cervix and the upper vagina, and the uterus would be draining into the external iliac lymph nodes. Axillary drains the upper limbs of the breast. There's the external iliac that we just talked about. The para-aortic drains the ovaries and the testes. The deep cervical drains the deep neck structures. In our next question, we have a 62-year-old woman presenting to the clinic for a follow-up appointment after a routine colonoscopy. Procedure was performed due to the anemia detected on the recent laboratory tests. During the colonoscopy, several polyps were removed for histological evaluation. The pathology report describes a 1.5 centimeter polyp with dysplastic features and a tubular architecture. She has no significant gastrointestinal symptoms or family history of the colorectal cancer. Which of the following is the most likely classification of this polyp? All right, there are a lot of different types of colon polyps. Some are harmless and others are very, very dangerous. And so she is coming into the clinic because she has some sort of anemia detected on her laboratory tests. And she has a 1.5 centimeter polyp. And then the pathology shows dysplasia in the tubular architecture. And so that's probably going to be tubular adenoma. And it's less aggressive than like the villous or the serrated types. It's still going to be precancerous. And so the answer is tubular adenoma. Especially since this is over 1 centimeter, the risk of cancer is going to start to be increasing. So because of the dysplasia and the tubular histology, it's going to be a tubular adenoma, which actually is the most common type of adenomatous polyp. They're neoplastic lesions with the potential to progress to colorectal cancer through the adenoma-carcinoma sequence. Let's look at some of these other choices, like the hyperplastic polyp. Well, that would be seen with no dysplasia, and that's common in rectosigmoidal colon, and these are actually benign and non-neoplastic, so that's not the answer. The sessile serrated polyp would be the sawtooth, those crypts in the right colon. You'd have serrated architecture, not tubular architecture. And those guys actually have a higher malignant potential, so we're glad that it's not that one. The juvenile polyp is going to be like hematomatous, and that's seen in children, and it's not going to fit our demographic for this one. And the villous adenoma, that has the finger-like projections and the high malignancy risk, and that's not going to be seen here. This has a tubular architecture, and so it's going to be tubular adenoma. It really is that simple. And a 1.5 centimeter dysplastic tubular polyp indicates tubular adenoma, and that is indeed a precursor to colorectal cancer. That's the bottom line. All right, in this question, we have a 58-year-old man. He has difficulty achieving and maintaining erection over the past year. He's got a history of type 2 diabetes and hypertension. Current medications include metformin and lisinopril. A thorough evaluation indicates no significant psychological factors contributing, and on examination, he exhibits normal secondary sexual characteristics. The peripheral pulse is intact. Blood work, including testosterone levels, is normal. Following discussion of treatment options, he's prescribed sildenafil to improve the erectile function, primarily by acting on what structure in the penile architecture? The answer is the corpora cavernosa. All right, so it's probably helpful to kind of draw this out. This right here is going to be the superficial dorsal vein of the penis. This right here is just the connective tissues that surround the corpora cavernosa. And this right here is the corpora cavernosa. And this right here is the urethra. And this does not have any role in erections, but this does. And what's wild is that 50% of men with diabetes experience some form of erectile dysfunction. And that's why we need the help of the little blue pill. And this definitely does not work on the urethra. It's on the arteries. It targets the corpora cavernosa. And those are the two spongy columns that fill with blood during an erection. And by blocking the PDE5, what it does is it keeps the cyclic GMP levels high, and it relaxes the smooth muscle, and it lets the blood rush in. And so it's the corpora cavernosa that does the heavy lifting there. No pun intended. Urethra would be a urine and a semen conduit. So that's A. Deep arteries of the penis are involved in perfusion, but sildenafil acts on the smooth muscle in the corpora, not the arteries themselves. Tunica albuginea, those are the connective tissues, and those are important for erectile rigidity, but they are not the actual target here of this medication. And superficial dorsal vein. The venous drainage is what you think of for that one, and it's not involved in the erection, initiation, or the PDE5 action. Next is the easiest question ever. 52-year-old man comes in, he gets a bunch of lab tests. Which of the following statistical measures is most appropriate to summarize the average 10-year cardiovascular risk? The answer is the mean. All we need to know about this guy is that the mean is the measurement of central tendency, and it's just like the average. That's all that it is. Mode is the most frequently seen. Medium is the middle value. The range, max, min, and the standard deviation is the variability. Mean is the mathematical average. Big population with normal distribution. That's going to be good. The median is good when the data is skewed. Standard deviation tells you how spread out the data is. But if we're summarizing the average cardiovascular risk, then use the mean. Simple, simple. There's the bottom line. You can read it if you'd like. Moving on to the next question. All right, in this question, we have a 5-year-old girl is observed by her school teacher to have yellow discoloration of her sclera. Concerned, the teacher informs her parents, who seek medical advice. The child has no significant medical history, and her parents report that she has been slightly more tired than usual, but has had no recent infections. On examination, the child appears jaundiced and has moderate splenomegaly. There are a whole bunch of findings here. The big ones are that the hemoglobin is low, the hematocrit is also low, at just 4%. A peripheral blood smear shows numerous spherocytes. Which genetic finding is most likely identified in this patient? All right, so let's just get the lay of the land for this question. This is hereditary, because she's so young. hereditary, and then it has what? Spherocytes, hereditary spherocytosis. It's a hemolytic anemia that's caused by defective red blood cell membrane proteins. And the one that we need to know for this question is the spectrin. So she's a 5-year-old girl and she's got jaundice, and that's from the increased unconjugated bilirubin, and also normocytic anemia and reticulocytosis. That's the marrow response to the hemolysis. And there's also splenomegaly, because that's the site of the red blood cell destruction and the spherocytes on the peripheral smear. So she has some sort of extravascular hemolysis, and so it's going to be a mutation of the spectrin gene. So there's spherocytes on the peripheral smear, and that's hallmarks hereditary spherocytosis. Splenomegaly is classic for extravascular hemolysis. Retic count is going to be high because the marrow is compensating, and there's normal MCV, and that rules out microcytic or macrocytic anemia, and there's no infections, and so it's not going to be like a G6PD or a parvovirus-related crisis. And it's the spectrin, the incrin, the band 3, the protein mutations. It's the red blood cell membrane instability that's damaged in this kiddo. And you have increased osmotic fragility. And so the cells will lyse easily in hypotonic solution. And that's what you do when you give them a fragility test. You see how easily they lyse. Also, you could see like some pigmented gallstones from chronic hemolysis. Splenectomy is definitive treatment, but it's usually delayed until after the age of 5. And this is autosomal dominant inheritance pattern. So the pathophysiology is that there's a mutation in the spectrin or the other membrane proteins, and that causes a loss of the membrane surface area. And now the red blood cells become spherocytes. They're like really, really round, and they have no central pallor whatsoever. And they are less deformable, and they get trapped in the spleen, the splenic cords. And the macrophages then destroy them. And so you get extravascular hemolysis that leads to anemia, jaundice, and splenomegaly. And so the spherocytes are going to appear on the smear. They're small, round red blood cells that do not have the central pallor, increased osmotic fragility, and there's a risk of pigmented gallstones. All right, and so the answer is going to be a mutation of the spectrin gene. Deletion of the alpha globin gene, that would be microcytic anemia. That's an alpha thalassemia. Mutation of the G6PD would be some episodic hemolysis after oxidative stress, like infections or like some fava beans or something like that. Some like drugs would cause that, but it's not going to be chronic and no spherocytes to be seen there. D is wrong mutation of the beta, because that's going to be sickle cell anemia or beta thalassemias, and those would be target cells, sickle cells, not spherocytes. And mutation of the hepcidin regulatory gene, that's iron overload, that's going to be seen in some sort of diseases like hemochromatosis or adult onset conditions that are like not pediatric, not hemolytic anemia. So here is an explanation. A lot of what we said: increased retic count and the spherocytes. The spleen is kind of breaking these things apart. The bone marrow is trying to help out, and that's the reason for the high retic count. There's the bottom line: spherocytosis, mutation of spectrin. All right, one of the easier questions. A 28-year-old man is found unconscious in his apartment, brought to the hospital by emergency department. Medical services. His friends report that he has been dehydrated and vomiting for the past 2 days. Due to food poisoning, on examination, his blood pressure is 80/60, heart rate is 110, started on intravenous fluids for hypovolemic shock. For the next 24 hours, his blood pressure and heart stabilize. However, on the second day of hospitalization, it's noted that the urine output has decreased significantly. Labs tests show elevated creatinine. Which part of the kidney is most likely to have sustained damage due to his condition? All right, now they love this question. Basically, this guy's got some sort of a hypovolemic shock, and that's due to his acute kidney injury. And the proximal tubule and the thick ascending limbs are the most ischemia sensitive segments of the nephron. And so this patient has some sort of a pre-renal acute kidney injury, and that's due to his hypovolemia from vomiting and dehydrating because of his food poisoning, and that decreases the perfusion. But after the fluid resuscitation, he actually is going to develop oliguria and rising serum creatinine. And now this has evolved into an intrinsic renal injury. So first it's pre-renal, now it's intrinsic, specifically the ischemic acute tubular necrosis. And so the part of the nephron that's most vulnerable to this is the proximal convoluted tubule, and that's because of the high metabolic activity and the oxygen demand that occurs there. And so the vomiting, the dehydration, the hypotension, those are the biggest things that cue us into his hypovolemic shock. So that's what I would like to key you into here, right here, is the shock. And so you give him IVs and his blood pressure is stabilized, and then the pre-renal turns into intrinsic problems with the kidney. And now you have decreased urine output on day 2, and that is going to be the transition to the ischemic ATN. And you have increased creatinine, and that's going to be a reduced GFR and tubular damage. and the most affected area is the PCT and the thick ascending limb. So the proximal tubule and the thick ascending limb have a high O2 demand, and there's a lot of ATP use for the sodium reabsorption that occurs there. And so you get ischemic ATN, that's going to be the muddy brown casts are going to present in the urine, and oliguria is going to be present despite the normal blood pressure, and that tells us that there's some sort of acute kidney injury. Oliguria is going to be the production of abnormally small amounts of urine. So the kidney is basically not working is what that's telling us. And there's a tubular injury that leads to a back leak and an obstruction. There's going to be some like delayed recovery phase. So it's going to be like weeks. You're going to have possible polyuria phase as well as the tubules start to recover. So the pathophys is we have hypovolemia, less perfusion, pre-renal azotemia, and then prolonged ischemia, tubular necrosis, especially in the PCT. Then you have damaged tubules and you lose the ability to reabsorb. And that would increase the creatinine and also decrease the urine. And you also get those slough cells from the cast that obstruct the flow, and that worsens the injury. And so our answer is going to be the proximal convoluted tubule. They love asking about that. That is going to be the most vulnerable to ischemia. So here's our wonderful bottom line. Acute tubular necrosis from hypovolemic shock typically affects the proximal convoluted tubule. Awesome. In this question, we have a 70-year-old woman presenting to the clinic with the complaints of continuous urine leakage that began soon after undergoing pelvic surgery to address a large uterine fibroid. She has since experienced constant dribbling of urine, even without any urge. Physical examination reveals a distended bladder, which of the following tissues is the most likely dysfunctional as a consequence of her condition. Okay, so a woman has some sort of a pelvic surgery, and then days later, she starts to leak urine nonstop, even though she doesn't feel like she needs to go. So that means that this is not going to be stress or urgency incontinence. This is rather overflow incontinence. And so the big problem here is the damage to the detrusal muscle, and that is made of the smooth muscle. Bladder contraction. And so now the bladder is filling and it gets over distended, and then the urine just starts to trickle out. You don't have any urge or any squeezing, it's just the overflow. So there are different types of urinary incontinence that are tested on this exam, and for that you need to know the anatomy as well of the bladder and the urethra. And after pelvic surgery, a common complication is the injury to the pelvic nerves that supply the detrusor muscle, and that's made of the smooth muscle. The distended bladder with a continuous leakage and also no urge to void is going to be overflow incontinence. And that's caused by bladder disruption of the detrusor muscle. So some sort of a detrusor underactivity is happening here. All right, so here's the explanation. Continuous leakage, no urge, distended bladder. Non-keratinized stratified squamous would be vaginal mucosa. It's not involved in bladder contraction. Hyaline cartilage would be in the joints and airways. There's no role here in the urinary tract. Skeletal muscle would not be involved here unless we're talking about like the pelvic floor. Adipose tissue does not have a functional role in the storage or voiding. And the skeletal muscle, I will say, is involved in stress incontinence, not overflow incontinence. If you guys found this helpful, like and subscribe. Here's the bottom line. Post-surgical urinary incontinence suggests smooth muscle dysfunction in the bladder control. Now stick around if you would like to have a nice recap song over the 10 topics that we covered in this video. Please share this, like this video, comment, let me know how I can improve, and we'll see you guys in the next one.
Mama's breathless, baby just came. Now her lungs filled up, her chest x-rays the flame. Her upper knee creeping, she's gasping on flat. Crackles in her bases, what's up with that? Heart's enlarged, DF's taking a dive. Months postpartum, she's trying to survive. No clots, no bugs, no mass in the lung. It's the heart muscle weak, ain't properly strung. Endothelial stress and the volume low. Got her ventricles stretched in dilated mode. Surgeon scalpel ready, where the vein at though? Trace it from the ankle, that medial glow. Runs up the leg like a straight up vine. Longest in the body, it's grafting time. Anterior to that malleolar spot. Subcutaneous baby, harvested hot. No need to stress, the leg drains well. When Saphenous steps out of the veins gel. Arterial Occlusion, postless. Yeah, sudden cold limb, pain screaming wild. Leg turn ghost like frostbitten child. No pulses distal, time ticking out. It ain't no DVT, that's Venice clout. This is fast and furious, arterial block. A clot shot south and the blood got locked. Could be AFib or valve debris. Now the limb's on fire with ischemic spree. Bleeding post-intimacy, lesion looking red. Pap missed the threat, now malignancy spread. Cervix is the spot, squamous cells gone rogue. Now where's the drainage? You gotta know the road. Deep in the pelvis, first stop on the line. Internal path, no superficial sign. Not legs, not gut, not the inguinal
pistol. Now that's the rule, architecture's tubular. Danger's real, it's Preventa's path on the adenoma deal. Villas got more risk, but don't relax. Tubular still stacks them neoplastic facts. Colonoscopy's key, find it before the blast. Or CRC, gonna show up fast. Till the navel, blood, blow, boss. Oh, can't get the rise, now it's time for a boost. Slick lil pill making blood get loose. Blocks PD5, let CGMP climb. Nitric oxide shining vascular prime. Hits the corpora, fills it with might. Penile engine, revving into the night. But don't mix with nitrates. Crash if you do, the hypertensive ride gon' flatten you. Can't get the rise, now it's time for a boost. Slick lil pill making blood get loose. Blocks PD5, let CGMP climb. Nitric oxide shining vascular prime. Hits the corpora, fills it with might. Penile engine, revving into the night. But don't mix with nitrates. Crash if you do, the hypertensive ride gon' flatten you. Can't end. Tubular tread. Kid looking yellow, got a big ol' spleen. Normocytic anemia, what does it mean? Spherocytes in the blood, retic count up. RBCs around and no central cup. Membrane issue,